Okay, welcome everyone to this month's webinar. My name is Karen Mullins. I'm a clinical researcher here at the UPMC Sports Medicine Clinic, and I'll be chairing this evening's session, which will focus on knee ligament injuries. So I'm delighted to welcome Professor Brian Devitt and Michael Eske, who's joining us from the US. To speak here this evening. So first of all, I'd like to introduce Professor Brian Devitt. So he's an orthopedic surgeon at the UPMC Sports Surgery Clinic in Dublin with a subspecialty in knee injuries, particular ACL reconstruction and multi-ligament injuries that we will hear about this evening. He completed his medical training at UCD and his specialist training in trauma and orthopedics at the Royal College of Surgeons. And he has a master's in sports and exercise medicine and is a full professor and chair of orthopedics and surgical biomechanics at DCU. So we're delighted to have him to take time out of his surgical day to join us this evening. And he's going to be chatting about collateral damage of the knee, leave it be or let me at it. So Brian, if you'd like to share your screen and work away, that'd be great.
Great. Well, thanks very much, Karen. Thanks for being patient with us as we try to negotiate teams. I have asked to change the order today because they're just in the middle of surgery. So apologies for that, but I won't rush the talk. So I'm just going to just get my slides up and ready. Are they okay? You can see them okay?
Yes.
Title of my talk today is collateral damage of the knee, leave it alone or let me at it. And I'm just going to discuss a few cases, which I think would be nice just to demonstrate this issue. So these are my declarations of interest, none of which are relevant to this talk today. So first case, the dark side of the knee. So this was the term given to the lateral side of the knee by one of my mentors, John Fagan. And these are all cases that I've seen within the past few weeks. So I thought they were particularly relevant to discuss. So it's a 30-year-old male electrician. He's presents with right knee acute injury. He's a Gaelic footballer and sustained the injury, was playing Gaelic. So as regards the mechanism of injury, he stepped into a divot on a pitch and hyperextended his knee. He went into a kind of a varus strain on his knee at the time. So he felt a pop in his knee and he fell to the ground. He was unable to weight bear afterwards and needed to be helped off the field of play. So a very common injury type of pattern we see. So in terms of his clinical findings on examination, when he came to me, he had a varus alignment. He had an antalgic gait, but no varus thrust, which is important. His knee range of motion was -10 to 135 degrees. So he tended to be a hyperextender anyway. And we often see this with people who hyperextend their knee traumatically. He had a moderate knee effusion. He had 2+ laxity of his lateral collateral ligament at 20 degrees of flexion, but only minor laxity at full extension. He had a negative Lachman, so his ACL was okay, and a negative dial test at 30 and 90 degrees. So it seemed to be just isolated to his lateral collateral ligament and not his posterolateral corner. So in terms of his MRIs here, I'm going to show initially here on the left side of the screen, the coronal MRI. So looking, this is the outside of the knee here. We're going to focus on this side where the arrow is. And what I'm looking for is the presence of any injury to the lateral collateral ligament. So we see here edema, which is gray and white, just over the lateral collateral ligament. We see that there is an injury to that. I'll go through that once more to show you that. And what we also see, I'll draw your attention to the inside of the knee, which is the medial side, just the area where he has a hyperextension bone bruising pattern. So once again, the lateral side here, where we see this area of just loss of continuity of the lateral ligament, but it's not a huge injury. It's a minor enough injury, and we see that by the extent of the lack of significant swelling, as you'll see in some further scans. So this axial view then shows us nicely. We see the presence of edema is white on these scans. So you see that here just anterior to the lateral or the fibula. And as we follow the fibular head up, we'll just stop here, you'll see some fluid around the lateral collateral ligament there. So that's just where it inserts the fibular head, and that's where he's sustained a relatively isolated injury. You'll also see just in the front of his femur now, just here is where he has that bone bruising pattern, and this is where he had the hyperextension type injury. So just go on to the next slide. And then this is the sagittal view. We typically would use the sagittal view for looking for ACLs. It's not as helpful for collateral ligaments, but you see here where there's whiteness around the lateral side of the knee, and this draws our attention to where there is injury. And just at the tip of the fibular head here, you see some increased signal. But the rest of his knee looks in good shape, which is good. And we'd always assess for a ACL injury in the setting of a POP. You'd want to outrule that as a source. And we see the bone bruising pattern nicely here. So this gentleman, it was a relatively minor enough injury. I would always go down a non-operative path with these patients. And in consultation, one of my colleagues, Andy Williams, who works in the UK, he often would leave these in the professional athletes to see if we can try non-operative management. The question arises, and certainly Michael, I'm sure, will have his opinion, whether the presence of braces or the use of braces is appropriate in this case. Typically, I look at the alignment of the patient, and in his situation, he was in varus. So I'm conscious that he has a bit more of a tension on the lateral side of the knee by virtue of this this alignment. So I did brace him for a period of at least 6 weeks after his injury. And it's also important just the timing from injury. A lot of times we get chronic patients into us, and really the value of brace is probably less appropriate in this scenario. And then we wanted him to rehabilitate, get his quadriceps activation going, which is important. The other factor for bracing, I think, is key for these patients is that they tend to not want to get into that hyperextension position because they have that bone bruising pattern. So we would often set the brace to just to 0 and not to -10 degrees, just to allow them to avoid that area where it causes irritation. Unfortunately, with this guy, he had failure of non-operative management. We saw him back just last week after 3 months. And once he started trying to do any type of activity, he was getting lots of symptoms of instability. And maybe it was because of his varus alignment he got this. And then he also had associated pain. And when I examined him clinically, he had a greater degree of laxity than he had at initial presentation. So in this situation, I elected, in consultation with him, to perform a lateral collateral ligament reconstruction. I haven't done the surgery yet, so this is an example of a posterolateral corner reconstruction, but this limb I'm showing here is how we do that lateral reconstruction, just at the origin of the LCL and the femur, and at the front of the fibula here, which is fixed. So we tend to reconstruct and repair over reconstruction for these cases. So next case is an interesting case. A sister of a good friend of mine. She's a general practitioner, but she had an injury, which I refer to as legs akimbo, that she had an injury of both knees while skiing. So she's a recreational skier. She fell. She was unsure of the mechanism of injury, and I was unsure of it myself in terms of how do you injure both knees at the same time with the exact same injury while skiing. So she fell. She had severe pain at the time. She had difficulty standing up. She had pain in both knees, which is a similar location over the medial aspect of her knee. And she had gross swelling, particularly in her right knee at the time. I tried to kind of think, how would someone injure both knees? And this is the image I came up with, and that's hence the title, legs akimbo. But I think there's more of a valgus strain to both knees, which particular relevance is the ski bindings didn't release, therefore putting a huge rotational load through the knee. In terms of her clinical findings, she came in a wheelchair, which is very unusual. I know this person. She's no shrinking violet. She's well able to manage. She was a good hockey player in her day, and she was really unable to stand assisted at the time. Predominantly, her right knee was the area that was injured most, and as a result, she had significant ecchymosis there, grade 3 MCL injuries. So she was gapping in full extension with a very positive Ligament test. Her left knee was lesser. It's all relative, I suppose, but she had lesser degree of MCL injury, grade 2, with the grade 2 Ligament, which is what we would routinely see. In terms of her imaging, we're just looking at her sagittal image here. So this is of the right knee. So I'll just orientate you. The kneecaps in the front, femur on the top here, tibia below, and then fibula here. So we're looking at the lateral meniscus. We do see there is an injury to the lateral meniscus as well. We've bone bruising here at the back of the tibia, and we have a ruptured ACL, as you see in the middle here. And then we have a torn, the PCL is intact, sorry, and then we have quite a bit of signal on the outside of the knee. And then I'll just show you the left knee then, in terms of the imaging as well. We see that the left knee, a very similar type of pattern of injury. Once again, the lateral meniscus ACL injury on the side. And then we look at the the coronal view, which shows us more this is here on the right. I'm just going to pause that. Sorry, it's a bit confusing. We see the coronal view here, where we see that lateral collateral ligament injury here, or the medial collateral ligament injury here, particularly at the femoral origin. So this is the lesser of the two knees. I think that the MRI for the right knee didn't actually display there, so apologies for that, but rest assured the right knee is a lot worse in terms of the injury pattern on the medial side of the knee. But you can just see where the area of edema here is how we identify the injury to the medial side of the knee. Okay, so I'm just going to go on then. So in terms of her operative findings, so we did an arthroscopy of this lady. We elected, the problem in her case is she doesn't have a good leg to stand on. So in terms of the treatment, we chose to treat her right knee, which is the worst of the two knees, as she couldn't stand on the knee, it was just collapsing. And it wasn't just related to her arthrogenic muscle inhibition, it was related to the stability of the knee. So I elected to do the right knee first and then just treat her left knee in a brace. I just felt it was too much surgery for her to undergo. So this is the arthroscopic images, just a selection of images here. I'll draw your attention to just the gapping of that medial side. The meniscus is floating, and that's what we often see in these cases where they've no attachment whatsoever of the medial ligament. This is the ACL here, which is a very high velocity injury. You don't normally see it to that extent. She also had a lateral meniscus tear, which I repaired, and some minor chondral injury around the knee as due to the velocity of and the force going through. So in terms of the ACL, this is what the ACL will look like in the next slide. Sorry, next one again. We see the ACL held with a screw on both sides, and this is the ACL we see in place here, which looks nice within the footprint of the tibia. And then I went on to repair and augment the lateral side of the knee. And this is the X-ray we see afterwards. The medial side of the knee we augmented, and just as the bone patellar tendon bone is a very good graft for ACL reconstruction, provides a really rigid construct. So the next case is the definition of madness is the title I've given. It's a 24-year-old male professional footballer. So he had recurrent medial collateral ligament injuries. And like most medial collateral ligament injuries, he was appropriately treated non-operatively initially. He had a contact injury for all of his injuries, but his first occurred in 2021. He underwent a very decent period of rehabilitation. It's often difficult for professional athletes to get that appropriate 12-week rehabilitation. They're often pushed back, but he was lucky that it occurred just towards the end of the season. But unfortunately, when he returned in 2022, he had a very similar type valgus strain injury. He had less rehabilitation following this. And then just this year, he had another contact injury with a 50-50 challenge. So he's a very tall guy, as we often see in soccer players. He had a varus alignment of his leg. His knee range of motion was hyperextension to good range of flexion. He had a mild effusion, grade 2+ laxity at 20 degrees of flexion, but he also had anteromedial laxity of both the deep and superficial MCL, and then a negative Lachman and pivot shift, and an intact PCL, which is important. So just his initial MRI scan from 2021, we're looking here on the medial side of the knee. I'll just draw your attention to the gap that we see at the proximal MCL, just up here, just to replay that again. So it's just, we're looking here at the MCL and the side here. You can just see that little gap there where he's had that injury to the MCL. So that's certainly a bad enough injury at the time, but he managed to get back to play and I didn't have many symptoms at that time. So looking then in 2022, we look at the images again. So very similar type of pattern. This time, I'm just going to pause that. He had bone bruising on the contralateral side of his knee, so on the lateral side here. And then we'll go on to show that he is this very similar. The area hadn't really healed where he had his previous injury there, but he has thickening of the superficial MCL, which I'll show you here, is that dark black structure. So he, as I said, he managed to get back from that injury. You can see there where he has fluid between the deep MCL and the side of the femur, but he seemed to tolerate with this injury. And it's oftentimes with these players, particularly soccer players, that instep, the way they kick with their foot, it can be quite difficult for them to get back following medial collateral ligament injuries. We probably treat them more aggressively nowadays. So then bring us on to his current injury. So this was a 50-50 challenge. His leg was kind of trapped and forced into valgus. So it's a bit more of a high velocity than his previous injuries. So we'll just see, first of all, we see within his knee that he's more effusion within the knee. So he's more fluid than had previously. And you'll see the distinct difference in his the appearance of his medial ligament. I'll just go slowly through it. Where you see here, he's got lots of edema proximally, but also distally, he's got a detachment of the MCL here, and that's the source of his problem now. You can see there's almost complete discontinuity with thickening of the injury proximally. So with this gentleman, then, you know, enough is enough. He's had 3 injuries. He's got gross laxity of his knee now, and really he wouldn't be able to kind of tolerate returning to play. So he went for a reconstruction of his medial collateral ligament, which is augmented with repair. So we used a medial collateral ligament reconstruction for him to reconstruct the medial ligament, and he's doing very well post-operatively. So next is an area called Hard Knock Life, which is a case of a professional, excuse the type of their professional rugby player. Very typical injury I'm seeing a lot of now, where they fall on a flex knee on the hard surfaces. So the likes of the AstroTurf pitches that we see. And this guy fell just on a flex knee. He immediately had posterior knee pain. He was able to play on, but needed to come off at half time because his knee felt very tight and he was uncomfortable. In terms of his alignment, very neutral alignment, good range of motion, mild effusion. His tibia was somewhat subluxed at 90 degrees, but I was able to feel a step off. And his posterior drawer was not massive. It was only 1+. Negative dial, negative Lachman, and all the other collateral ligaments were intact. So this is a very common injury we see. This just shows you the grade of the step off as we use it. So in his case, he'd only less than 1.5 centimeters between the 2 sides, which was good for him. So we elected to treat this non-operatively. One of the other little tests I often do is, you can see on the left image here that subluxed tibia, and on the right that the tibia is reduced. So what I often do is place a pen just over the tibial tubercle, and you see the pen will come off, won't touch the front of the patella on the uninjured side, and when you place it on the injured side, it touches the patella. So this is a nice little technique just to show patients how much posterior subluxation occurs. So in his situation, I treated him immediately. He was a professional athlete, so he'd access to braces, but I treated him immediately in the posterior PCL brace, which is dynamic, so it provided that anterior load to his knee. And he was able to just let things settle for the first 6 weeks, and was able to then get into some training within his brace, keeping his quadriceps activation going, reducing the effusion initially, and he managed to get back to play after 3 months and has done very well since. A lot of these athletes will do well initially, but may decompensate with time if they had further injury. But the treatment of lower grade PCL injuries, I would certainly recommend non-operative management. And then finally, so this is his MRI scan, and just to show you there's just the injury pattern. So no lateral sided injury, very minimal effusion by the time he got to me. ACL is intact. You see that here. A little bit of signal within it, which is not uncommon. But you see that the PCL, which is normally jet black, has been injured through its mid-substance. And then no evidence of any injury to the collateral ligaments here on the lateral side here, or the medial side here. So he did very well. You can just see the PCL there with a lot of edema around it. Okay, so then final case is the full Monty. So this is the case that I didn't think we'd see very often within the private sector, but I've seen it more often than I expected. This is a 21-year-old male student. He had a contact injury where an opponent fell directly on his leg. So his leg was hyperextended and a significant valgus strain. He felt a pop, excruciating pain within his knee, gross swelling immediately, instability. He attended an emergency department where he was placed in a Zimmer splint. When he attended me, he had neutral alignment of the unaffected leg. He couldn't weight bear on his affected leg. He had a fixed flexion deformity, as is often the case when people are placed in Zimmer splints, but range of motion was very limited from 10 to 80 degrees. He has arthrogenic muscle inhibition. That's a new system that we're using. They have a sonnery classification, but essentially he was unable to actively extend his knee and was holding his knee in a fixed flexion, despite us trying some maneuvers just to get him to relax his hamstrings. But so he needed a lot of work before he'd have surgery, this guy. gross effusion, as is in keeping with the high grade of muscle inhibition. Grade 3 grade 3 MCL and Lachman, which I'll show in a second. He had a grade 2 PCL. In the prone position, he had increased rotation in 90 degrees, and that's typically indicative of PCL injury, although his lateral collateral injury was intact, and most importantly, neurovascularly intact, which is key. So just looking at his MRI scan, so this is a bit of a horror show. You'll see the amount of edema within the knee, large bone bruising pattern on the outside of the knee here. I'll just show you that further. ACL rupture here, PCL injury more at the femoral origin, and then he had a root tear to his medial meniscus, as is very common with this type of injury pattern. And you can see the meniscus is hanging off the back of the tibia. So the tibia is not in a good position. It's been just the position has been distorted by virtue of the increased or the laxity of the medial side and posteromedial aspect of the knee. So looking at his knee front on, then we see the kneecap here. This is the lateral side of the knee here, which is relatively intact, but you can see the extensive damage to the medial side of the knee here, with the deep MCL being taken off the tibia, and his ACL has been ruptured, his PCL has been ruptured, the meniscus is subluxed, you can see that there, and the meniscus root has been avulsed. So this is a really bad injury. So you wouldn't want to be planning to do a talk after this operation. You wouldn't be able to speak. So this is his clinical examination under anesthetic. So there might be some audio here, but we can just see the degree of posterior laxity here. You can see grade 3 laxity, so full extension, and able to open up his knee very, very easily, and much more so in 20 degrees on knee flexion. We then just assess the lachlan, and to get that gross lachlan, you have to have most of the PCL gone as well. And then his lateral structures were intact, which is good. And then finally, we flex up his knee, and we try to just look at the level of subluxation of the tibia. And then you can do Slerkin's test, where you're rotating his force into external rotation, just to see if his deep MCL is injured. So he's injured the deep MCL entirely. So just the arthroscopic findings are not very helpful here, but I just wanted to show them. You see in the knees are full of blood, so it's really hard to see initially within the knee. And we look at this is the floating meniscus sign, which I showed earlier. The pictures get a bit more clear, but we really see lots of cartilage damage within the knee. These are really horrendous injuries. This is a notch where we've nothing within the notch at all. And then we look further, we see how much the ACL has been torn there. This is the PCL, and we've taken away the ACL, which is very wispy. These are just our access. This is where we put the PCL tunnel right at the back of the knee. So I'm looking in the knee from the posteromedial portal here, and this is where we put in his graft at the back of the knee. I don't know what happened there. This is just us. Sorry, I'll go back there. This is us doing the let me just go back here. This is the root. Oh, sorry, it's just flicking forward a bit. This is the root repair here at the back, where I'm passing the sutures in to repair the root of the meniscus. I haven't done the medial collateral ligament yet, but that will be done very shortly, and that closes down the side of the knee. We then have to do ACL, PCL at the time, so there's no kind of messing around with these cases, because the tourniquet is up, so you quickly run out of time. So you really have to have a good team working with you. This is the tunnel for the ACL here. And then I'll show a picture of just the grafts being positioned. So this is both the ACL. Sorry, it's not very easy to go see this. That's the ACL there. Excuse me a sec. ACL and PCL there together. So you see the nice reconstruction. That's very anatomical as you see it. So I was very pleased with how it went. And this is the x-ray of this patient afterwards. So a lot of metal work, a lot of time has gone into reconstructing the knee. They wouldn't get an award for the best x-ray. This was just taken in recovery, and just to make sure everything was in the right position. And this is it from the side there. So once again, a little bit rotated, but the result was good. So in conclusion, a lot of these injuries are considered collateral injuries, but really we have to assume that they're knee dislocations until proven otherwise. Clinical examination findings are key, and then marrying them with the radiological findings is really important. You really need to set yourself up for success And I think in this situation, you need to plan your surgery. You need to plan how you're going to, manage these patients post-operatively. And Michael will talk to us about bracing, etc. But they are a difficult group because they don't really respond just like an ACL. And the patient needs realistic expectations. I think right from the start, you just have to manage their expectations. They always talk about when they go back to sport, and my emphasis is that we need to get your knee moving. We need to get you walking first, and just, take things day by day is really important. So thank you very much. Good. So I'm happy to take any questions you might have.
That's great. Thank you so much. Yeah, we'll take questions for Professor Devitt now at the moment because he's going to head back to theatre. So we have a question here. What are your thoughts on using synthetic grafting intra or particularly extra articularly for multi-ligament injuries?
So great question. I have no problem using them extra-articularly. I don't particularly like using them intra-articularly. I think that, certain people would use them in multi-legs, but in my mind, I think we do have plenty of grafts available to us. You just have to be smart in how you use them. I have a fear that they cause too much synovitis within the knee, particularly in the context where you probably have some condyle damage as well. I've less fear of using them extra-articularly, and I'd often use them as an augment for reconstructions, as I did in the case of that soccer player. They just provide a little bit of a strut to allow us to move earlier. We refer to them as internal braces, is one of the phrases one of the companies have used. But so I tend not to use them internally, but definitely externally.
Okay, great. My question, the lady that injured herself skiing, you said that you operated on the right knee first. Did she then go on to have surgery on the left? And if so,
No,
what was the time?
not yet.
No, okay.
Yeah, so I've said to her, I said, I wouldn't. She's back at 3 months now. Just saw her this week, and that's why I brought a case. She's still a little bit sore on the right side, and she's actually managing reasonably well on the left side. She does have a positive Lachman, but she won't feel instability yet until if she gets back to kind of pivoting sports, and she's not really interested in that. So we said we'll just hold fast now. It's a major undertaking. She's a mother of young children as well. So I think you have to treat the person first and then the injury kind of second. I think in this case, we'll probably hold off and probably avoid surgery if we can, for as long as we can.
Great. My other question then is, what is your policy on post-operative bracing?
Yeah, so I think for some of the multi-legs, I do use post-operative bracing more but just for protection, and particularly as they tend to struggle with just getting their muscle activation going. I think from my point of view, I am a bit reluctant to restrict their movement in the brace. I like to keep the brace moving, from -10 to 120, as most of them will move, just to allow them to get that full extension, because that's what really bothers us afterwards, is getting that arthrofibrosis. So I'm really keen to get them moving. I'd be less if it was an isolated MCL with an ACL, and I'm very happy with the repair and they've neutral alignment. I'd be happy to get them out of the brace pretty quickly, or not use it at all in some circumstances. But typically 6 weeks for just a routine collateral ligament, but for PCLs 3 months.
Very good. So if anyone has any other questions for Professor Devitt, please speak now or forever hold your peace, because he's running back to theatre.
Tim can answer. Tim knows everything I know, so
yeah.
well, he thinks he does. So.
No
I'm
problem.
sure Michael
That's
will know most of them as well.
That's great. No, thank you so much.
Okay.
That's brilliant. Thank you. We'll let you go.
I'm happy to take if anyone wants to email me through the UPMC system as well. I'm very happy to take any emails of queries and stuff like that if nothing comes to mind now.
Perfect. Thank you so much.
Okay.
So
thanks very much.
Bye-bye. In a slight little change to our format, where we would normally send out a paper to critically review, we're joined this evening by Tim McAleese. He's a trainee orthopedic surgeon and who's currently undertaking a research fellowship, I should say, with Professor Devitt, and he's going to talk through some of the literature around our topic today. So that's great, Tim, if you want to take it away.
So I suppose the role of my talk is to provide a background to the decisions that Professor Devitt makes. So I'll just go through the anatomy, the biomechanics, clinical assessment, grading system, imaging, and then the evidence around the management for first the medial side, then the lateral side, and then hopefully the reasons, the decisions made around each case make a bit more sense. So starting with the medial side, isolated MCL injuries are probably the most common knee ligamentous injury there is, but they're probably the least common to have surgery, and as little as 0.2% in some epidemiological studies undergo surgery. So it's probably more important to think about the medial ligament, not just, or the medial side of the knee as a ligamentous complex as opposed to just an isolated MCL, and to consider the posterior medial corner, which is what actually requires surgical intervention. So the diagram on the left is from a nice anatomical study by Leprad's group, published in 2007. They've done extensive cadaveric dissections of the medial and lateral side of the knee in different layers, which are quite nice to look up if people like anatomy. Left side shows the three main ligaments in the posterior medial corner. First is superficial MCL, which is the longest ligament. It has its origin in the medial epicondyle and inserts on the tibia deep to the pes anserinus. Deep to that, there's the deep MCL. Naturally, it's shorter and it's continuous with the medial capsule. It has a meniscofemoral and meniscotibial portion. And then a really clinically significant one that might not be as commonly known is the posterior oblique ligament, which is not, when dissected, not quite clearly a ligament as the MCL, but more a thickening of the capsule. And it provides a rotational stability, and it fans out to meet the semimembranosus expansion and combines with the ligament as well. Diagram on the right shows the different origins of those three core elements of the posterior medial capsule, which is important for when you're doing a repair on the medial side or reconstruction. So the medial ligament complex, just discussing what those three ligaments do in terms of biomechanically, helps us understand how we should reconstruct them. So the superficial MCL is the main restraint to the valgus force. It also provides external rotation and internal rotation limitation. Crucial for the clinical exam is that it's most taut at 30 degrees. The deep MCL is a secondary restraint to valgus, but also provides limitation to anterior translation, which is important for clinical exam as well. And the posterior oblique ligament is primarily a rotational restraint, but also provides a valgus restraint as well, because of where it is in the posterior medial knee. And then comparing it to the superficial MCL is that it's tight at 0 degrees. So the diagram on the right shows a classic mechanism, contact mechanism of injury to the medial ligamentous complex. You have a valgus force plus minus external rotation. And I suppose a non-contact injury would be in something like skiing, where patients have their knee flexed between 0 and 30. And then like the case we saw from Professor Devitt, they have a valgus and external rotation force with that. On clinical examination, important to look at the overall alignment of the patient's lower limb. Patients with valgus constitutional alignment or valgus thrust are kind of more high risk for failure of conservative management. Look at their overall laxity using the Baton score, and then if they have concurrent ligament injuries, ACL, PCL. So superficial MCL, as you can see examined there, is tested at 30 degrees and shows laxity.